There was, at this ASCO, our fellow that I mentored, Dr. Julie Braish, has analyzed a very large cohort of myelofibrosis patients, over 600, and look at the impact of JAK2 allele burden that we divided at the less than 50% and more than 50%, which is kind of historical homogeneous versus heterogeneous JAK2 allele burden, and then the impact of cytopenias. So the whole idea came from myeloproliferation, which is a disease presented with more white cells, more spleen, more symptoms, and then myelodepletion, which is more cytopenias, either anemias or thrombocytopenias. And those two distinct spectrum of myelofibrosis patients started to come up lately when we've developed more JAK inhibitors, of which some, especially Ruxolitinib and Fujatinib, are myelosuppressive, but the two latest one, pacritinib and momelotinib, are not. So that has more importance in there. And then comparing the outcome of these patients showed us quite surprising results, which we actually more completely confirmed that the counts matter, not the JAK2 allele burden, not the phenotype in terms of primary myelofibrosis or myelofibrosis evolved from ET or PV, but the blood counts. So patients that had no cytopenias, irrespectively of the white cells, did the best. There was a median survival of about 70 months, and there was regardless of the JAK2 allele burden or whether they were PMF or post-PD, post-ET-MFs. Patients that had cytopenia but no proliferation, that was defined as white cells over 25,000, did in between about 40 months, and then patients that had cytopenia and high white cells, again irrespectively of the types or JAK2 allele burden, did the worst with medians on only 19 months. And then we looked briefly on the same cohort about what could Ruxolitinib, which was the first approved JAK inhibitor, do, and surprisingly, even to me, it had showed improvement in outcome in all patients exposed to Ruxolitinib, irrespectively of these groups. There is certainly more work to do to specifically look at the dosing, at the duration of the exposure, and particularly in the groups with cytopenia and cytopenia with proliferation. But in those patients had also improvements in survival if they were exposed to JAK inhibitor by at least 30 months, which is a significantly difference. So we have to look into the factors why other patients were not exposed to JAK inhibitors, whether there could be any confounding variables, and so on and so forth. But so far, I was very excited about this. So we confirm counts matter, JAK2 allele burden may not so far.